So the gentleman.
Yes, you mentioned that germs stick to the artificial joint. Well, with antibiotics, how do they attack the germ on the joint? You haven't got a blood supply going there, so how can you get to that germ?
Okay, you're absolutely right, they can't.
Oh.
Very good question. So if we wanted to deal, the question was, if these germs are very sticky, how do the antibiotics get rid of the germ? Well, the answer is, for practical purposes, they can't. So when the germ sticks, let's assume this is the surface of an artificial joint here, and you've got one germ sticking there. It slowly multiplies, starts using its mobile phone communicating, and then becomes thicker. So that once fully established, the germ layer will be between 500 and 1,000 deep. Okay? Now, if you give someone antibiotics to try and kill this layer of germs, the antibiotics are up there, okay, and you've taken them by some matter of intravenous or tablets. The bloodstream will deliver them to the surface layer of germs, and that's it. It will kill the surface layer of germs. The antibiotic will not be able to penetrate down through this layer. So, for penetration reasons alone, cannot kill that layer of germs. The other thing about this layer of germs is that, as you said, it hasn't got a blood supply. And I think when you said that, you meant it hasn't got a blood supply, therefore the antibiotics can't get there. But equally, oxygen can't get there. So what that means is that these poor germs, if I can use the expression, these poor germs haven't got much of an oxygen supply either. And so what they're doing is they're hibernating. And to hibernate, they have to switch off almost all of their own metabolic life cycle processes. And having switched off their own metabolic and life cycle processes, antibiotics, which work by interrupting a life cycle process, actually have nothing to work on either. And those two factors together, the hibernating state and the thickness of this layer, means that antibiotics have effectively no ability to destroy this layer of germs. They can destroy it if you give a high enough dose. But for example, if you take penicillin for group A strep, which is a germ, the penicillin dose you need to give is 1,000 times greater than the dose a human being can tolerate. So you could kill the layer, but the patient wouldn't survive the experience. Which is why the strategy for getting rid of so much bone and joint infection is what Martin McNally and David Stubbs do, which is actually to take out the section of bone completely and put it in the bin. It's essentially to acknowledge that you can't get rid of the layer and put it in the bin. Or, in the case of these kinds of devices, is to do a so-called two-stage procedure, where you acknowledge you can't get rid of the layer, so you take the device out and put it in the bin, and with no device in there, you then treat it with 6 weeks, let's say, of intravenous antibiotics. Okay? That should then have eradicated the infection. You then put a new device back in. So that's a so-called two-stage procedure to eradicate infection, which have about a 90% success rate. Does that answer the question?
Yes, I think it does.
You're describing conditions which are rare and serious and don't happen in individual hospitals very frequently, so that individual practitioners don't build up a wealth of experience of managing the few that they get. Another condition, while you were describing it, childhood leukemias are fairly similar in that respect, and they have a national register, and children with leukemia all get put into UCAL trials. And effectively, they're given the same treatment throughout the entire country. Even if they're treated in Scotland or Devon, they're given exactly the same treatment, they're entered into the same trial. Is there not an argument for doing the same thing with this?
There would be, and in fact, myself and Tony Berrant have agonised at some length to try and work out how one would put together a registry or something like that around bone and joint infection. I think one of the differences between, for example, a cancer, is that if you take a cancer, there will be a described number of drugs that you can use, as in, I'm just going to say 6, I don't know what the number is. And you could say, well, we're going to have a register, and the suggested treatment is going to be A, B, or C, using these 6 drugs. The problem when it comes to orthopaedic infections is that by anatomical site alone, you have dozens and dozens of sites. By artificial device, you have literally hundreds of devices made out of all sorts of different material. The other thing about orthopaedics is a lot of the procedures are staged, by which I mean you do A, then you do B, and then you do C. The other thing is that although you may have a few leukemias, when it comes to infections, there are literally hundreds of different germs, and there isn't just 6 drugs that you could treat them with, there are hundreds of antibiotics that you may need to use to treat them with. Now, having said all of that, that, in my opinion, isn't even the difficult bit of trying to work out what to do with the registry. The really difficult bit is the sculptor, by which I mean simply that it would be wrong of me to pretend that the outcome of bone infection is critically dependent on myself as a physician getting the organism and the antibiotic right. It is critically dependent on the sculptor, by which I mean the surgeon. So much has got to do with surgical technique, the way the surgeon handles the soft tissues, the bony tissues, and so on. And that seems to be so highly variable, with so many different described ways of doing it, and it's so difficult to standardize, that I think having a register of how one does that will be a lot more complicated to achieve. And it's been one of the difficulties for us, and in fact, it comes up every year or so when we're talking to colleagues in Europe and the United States. We're trying to work out, well, could we do a trial together? And the answer is, we usually can't do a trial together because in the States they use a different surgical technique to the one that we're using here. We both get similar results, let's say, so it's not as if someone's doing something appallingly wrong, but we can't it's all apples and oranges, it's very difficult to compare. But in principle, I think you're absolutely right. A well-established register would be a good thing. There are some partial registers in existence already in this country, but there's no register covering all of bone and joint infection.
You mentioned earlier in